Thank you. My friend David told me this story. When David was a resident in the emergency room working an overnight shift, one night he and two other tired residents were complaining, asking, why is the pizza we have ordered not come yet? And their pizza complaints were interrupted when a nurse shouted, GSW, trauma 1, no pulse, no blood pressure. And as the residents rushed to the gurney, they immediately recognized the unconscious teenager. He was the delivery boy from their favorite all-night restaurant, and he had been mugged bringing them dinner. This made them work even harder. The surgeon cracked open the kid's rib cage, but the bullet had torn through his heart and they couldn't even stabilize him to get him to the OR. So after 40 minutes of resuscitative effort, they finally called it. Time of death, 4 a.m. These three residents shuffled quietly back into the temporarily empty waiting room and just sat down silently until my friend David said what all three of them were thinking. What do you think happened to our pizza? Joe's the one who found it. He walked outside the emergency room bay, and the pizza had been dropped just steps from where the kid had been shot. Dropped the pizza to run from his muggers in this impoverished urban neighborhood. It's been dropped face up. Joe picked up the pizza, brought it back to the area they were sitting in, and sat it on the table. And the three residents just sat quietly and stared at the pizza until one of them made a joke. How much you think we ought to tip him? The residents laughed, and then they ate. Now, my friend David finished his residency over 15 years ago, but when he told me this story, the urgency of his voice made it feel like this event had just happened last night. You're the ethicist, he said. Was it wrong to make a joke? And as a medical ethicist, this is the kind of story that grabs me because it's about moral distress, it's about power imbalances between doctors and patients, and it's about good people making surprising choices. Ethics is normative, so David asked the right question. What's the right thing to do? What's the good thing to do? Or when all the options you have are bad, what's the best one to choose? But I'm also in a field that's called medical humanities, which isn't about right and wrong, it's more about the what and why of medicine. So, rich medical humanities programs, like the one I have the pleasure of being in at Northwestern, can have a faculty from a multitude of disciplines. Philosophers, medical historians, medical anthropologists and sociologists, literature and narrative people, comparative religion, performance studies, and the errant lawyer like myself all gather together. And we're not owned by our home disciplines in the undergraduate world. We're in the medical school in a shared department and looking at problems in medicine together. Thinking about both the practice of medicine and the practice of illness from these other humanities disciplines, and doing what I like to think of as a 360 review in disciplines. What are the disciplinary insights from these other fields? What can they bring to this problem in medicine? Separate from and in addition to a bioethical analysis. So at Northwestern, because we teach our students to use both medical humanities and bioethics approaches to similar problems in medicine, to use both this normative right and wrong and this descriptive what and why approach. This morning, in addition to thinking about the content area of Gallows humor, I want to model for you this approach and this unique way of using the medical humanities. And then at the end, we'll circle back to David's original question. Is it possible that some jokes that healthcare providers make could actually be called unethical? All right? So, why would physicians joke about life and death situations and the patients they're there to help? After Freud did his dream work, he wrote a book called Jokes and Their Relation to the Unconscious. This is in 1905. In this book, he argues that the jokes we make are just as revealing as our dreams. And he proposes some interesting ideas about the important psychological functions that joking might serve. So the first function is avoiding what's called the internal obstacle. Freud argued that the more shame or repression or fear we feel about something, the harder we'll laugh at a joke about it. So a good joke about topics like death, sex, excrement, race, or religion are always going to get a laugh. according to Freud. And they do that by dodging the inhibitions of our prissy, civilized superegos that are saying, you can't talk about that. So if we feel tense that we can't talk about it and someone makes a joke about it, the inverse proportion of our laughter will be the psychic tension that it relieves. So jokes about things we're anxious about will always get a laugh, and they'll do so in proportion to how anxious we are. And with death, that's a lot of anxiety. Freud also proposed the concept of external obstacles, that joking will help us avoid external obstacles, and those are powers beyond our control. And the idea is that the second function of joking is to help us cope with these things outside of our control. Because when you can't address your problems directly, laughter is a more helpful response than anger. Joking about the boss is a substitute for fighting with the boss. And if we can get other people to laugh with us, we might feel our relative power grow. A joke is a rebellion against an oppressive authority, and few authorities are more oppressive than death, illness, and injury. In one of the ultimate examples of external obstacles, in Man's Search for Meaning, concentration camp survivor Viktor Frankl describes prisoners who cracked jokes about their horrible circumstances. Quote, "Humor was another of the soul's weapons in the fight for self-preservation. Humor, more than anything else in the human makeup, can afford an aloofness and an ability to rise above any situation, even if only for a few seconds." A philosopher named Ted Cohen, to switch disciplines, argues that sometimes we joke not for distance from things, but for connection. Cohen uses the example of pointing out a beautiful sunset or a beautiful piece of art and saying to people, come look at this, you've got to see this, this is so great. And he asks philosophically, why do we do that? Is it just that because I'm so generous and I want to give my friend the gift of seeing this wonderful thing? Cohen says, no, we're not that great. That we want to share these things because it's a way to establish intimacy. If my friend agrees that the sunset's beautiful or Guernica is provocative, I'll feel closer to her. And Cohen argues the same is true for jokes. If you laugh at the things I'm joking about, it tells me that we're alike, that we see the world in a similar way, and that maybe you get me in this important way. In that sense, joking serves the vital social and psychological function of cultivating intimacy and establishing and affirming community. Cohen points out a second interesting reason we make jokes, because laughing at absurdity is the only way to coexist with it. In Cohen's words, when we laugh at a true absurdity, we simultaneously confess that we cannot make sense of it and that we accept it. Thus, laughter is an expression of our humanity, our finite capacity, our ability to live with what we cannot understand or subdue. We can dwell within the incomprehensible without dying from fear or going mad. Thinkers like Freud and Cohen focus on the emotional reasons we joke, but I think that some clinicians' laughter in certain situations is better explained by cognition. This is illustrated in an essay about a hospital cafeteria snack break that a fourth-year medical student at UCSF named Rachel Sobel published in the New England Journal of Medicine a few years ago. And I'll give you a little snippet from the story she tells. She says, the medical teams on the overnight shift were eating ice cream together, talking about the funniest beeper pages they'd gotten in the middle of the night. For example, quote, "Doctor, your patient's on fire." And we laughed until we could barely breathe. So let's just forget this deep analysis of bonding and coping for a minute. One reason that clinicians might laugh at the page, "Doctor, your patient is on fire," is a cognitive response to incongruity. There are three incongruities I want to point out to you. The first incongruity in that page is content. People don't usually catch on fire. Less so in a hospital. I don't know how y'all do it at Louisville. But that is a very incongruous concept. A patient on fire is surprising. It just doesn't quite add up. The second incongruity is the delivery. Someone you know is on fire, it seems like the kind of thing you'd hear yelled, not get through the same medium that says, "See you at 3." It's a very blasé way of delivering this information. And the third incongruity is linguistic. The present tense, your patient is currently on fire, frames the person sending the page as a blasé typist who's paging a doctor instead of throwing a bucket of water on someone standing next to them in flames. A character's underreaction and their overreaction are standard comic scenarios, right? We're all very familiar with that, and they're both are variations on incongruity. That is something that just makes us laugh. Human brains trained in pattern recognition, particularly a clinician's brain, which is extra trained in pattern recognition, quickly spot pattern disruption and jump to the startled response of laughter. But in Sobel's analysis of the exchange, this fourth-year medical student dutifully chastises herself for failing her professionalism oath. Quote, "The purest definition of professionalism dictates that patients should be respected at all times, even behind closed doors." But I think that labeling this student's laughter unprofessional isn't a purist interpretation of her oath to treat patients with respect. Narrative analysis suggests it's an inaccurate interpretation of the laughter, because the object of the laughter, I think, was not the poor flaming patient. This student concludes her essay by wondering how we can ever reconcile, quote, "human imperfections with our desire to abide by the highest standards of professional conduct." But I want to offer a different point of view. I don't consider her laughing at the retelling of that page as an imperfection. In physicians, a rapid and consistent ability to spot what's wrong with this picture is actually a mark of perfection. And I'd really hate it if our medical students at Northwestern or otherwise mistook our commitment to professionalism for a priggish campaign against pleasure. With Sobel's example, I'd argue that laughing at the incongruity of that page is not inconsistent with empathy for that actual patient. Switching disciplines once more, another analysis looks at humor as a form of rhetoric. Writer George Saunders says this about the gallows humor that Kurt Vonnegut employs in his war novel Slaughterhouse-Five. Quote, "Humor is what happens when we're told the truth quicker and more directly than what we're used to. The comic is the truth stripped of the habitual, the cushioning, the easy consolation. This rapid truthing is what Vonnegut does with war." And I want to say, I just love that term, rapid truthing. It made me think differently about a joke I heard a senior neonatologist tell a few years ago, about over a decade ago. A group of medical professionals and ethicists were considering the case of a neurologically devastated newborn. The discussion focused on the medical facts for a really extended period of time. You know, people saying, what about this test? What about that test? What about ABC? How can you predict these things? Until Bill ended the debate by saying, look, he's more likely to be second base than play second base. As someone who was new to these types of conversations at the time, I was shocked. But I also noticed that this very crude summary of the baby's medical status served the function of moving the conversation on to the next set of issues, like what range of options should be available to parents in situations like these. And there were a few fleeting expressions of disapproval, a few eye rolls and a little head shakes in Bill's direction, but no one seemed to disagree on the merits, and it seemed to free them to move the analysis forward. So maybe this neonatologist was playing the role of court jester, using a joke as a functional shorthand to speak the truth no one else was willing to say. Maybe this is an example of a joke serving the function of rapid truthing, to use Saunders' term. Or maybe it isn't. On the other side of the rhetorical analysis, Freud points out the danger of humor, which is that humor is a thought or an argument wrapped in a joke. Quote, "While argument tries to draw the hearer's criticism over onto its side, the joke endeavors to push the criticism out of sight. There's no doubt the joke has chosen the method which is psychologically the more effective." So the principle is that thoughts framed as jokes bribe and confuse our powers of criticism. If we laugh at them, by definition, we're not in critical mode. And if I'm the person in the conversation who says, wait, I want to respond to that joke by challenging its underlying presumptions and assumptions and I'm a drag, right? Because everyone laughing will resent having to stop laughing, stop playing, and go back into analytic mode. So positions promoted through jokes somehow seem stronger than those supported by arguments. Positions supported through jokes also have a built-in protection against criticism, which is, hey, it was just a joke. Gallows humor shows up in fiction, too. The physician's classic is The House of God, a novel written in 1978 by a physician that follows the training of a fictional new resident named Roy. Please raise your hand if you've read The House of God. some fair number of people in the room. This narrator, the resident Roy, the author positions him in a way that he's green enough to still have one foot in lay culture that says this way of joking about patients is not right, and one foot in the medical culture that says you cannot be exposed to this much death and behave any other way. This book is funny and it is mean. One objection that people have to the humor in the House of God is it seems to to violate the principle of joking up. The idea that it's okay for the less powerful to make fun of more powerful people or groups, but the reverse, joking down, is not okay. When we joke about people less powerful than ourselves, the punch of the punchline can just feel too real. Joking up is why medical students can mock us professors in an annual variety show. Joking down explains why if professors put on a show making fun of our students, that would be a transgressive act, right? But embedded in this concept of joking up is an assessment of the relative power, right? We have to agree who is above me and who is below me. And I think that assessment can actually be very contested and very complex. With the House of God, it seems relevant to me that the book was written in 1978 because that era was the height of a particular kind of physician powerlessness, when physicians had a new ability to sustain life with new technologies like ventilators, but didn't yet have cures for many of the conditions that put people on ventilators, and didn't have the legal authority to stop this non-curative treatment for permanently unconscious people whose families were saying she would have never wanted this, stop torturing her. So underneath all the book's cruel macho humor about patients and sometimes nurses and people lower in the pecking order in the medical training, I think that the joking seems to be driven by an incredible underlying helplessness. Gallows humor is humor that makes light of a frightening or painful subject matter, and that certainly includes a physician's own impotence. The way the characters in the House of God mock vulnerable groups remains to me very hard to stomach. But attention to the power that narrators wield provides a partial remedy. The one time I taught this book to medical students, I did an assignment where I invited the students to pick a particular scene of their choice and rewrite the scene from the point of view of the patient or the nurse. So they couldn't change the facts of what happened in the scene. So if a doctor and a nurse slept together, or if a patient had a certain medical situation, whatever the issue was, they couldn't change the facts. But in their versions, they wrote it so the new narrator mocked the physician character. Their rewrites were amazingly successful, both in the cruel jokes that the new narrator then made about the physician, and in their illumination of humor as a deployment of power. So understanding literary construction can lead us to this framing. When someone wonders if it was wrong to make a joke, maybe they're really asking about the use and the abuse of power that comes with asserting oneself as the comic narrator of someone else's tragedy. Physicians are not the only ones who joke about death, but gallows humor typically occurs between peers. Sociologists, to switch to another discipline, have documented the way all work groups develop a backstage language that's not meant to be understood by outsiders, right? It's teachers in the teachers' lounge, firefighters together in the firehouse, war correspondents at the hotel bar. None of what they say backstage, when it's just us, is meant to be heard by anyone outside of the group. And gallows humor by healthcare providers certainly falls into that category, in my opinion. Gallows humor might be a demographic postscript to you had to be there. It's you had to be us. And with in-group backstage laughter, asking who us is can reveal subtle divides within medicine. A rehab physician told me that she feels like rehab physicians are entitled to joke about disability, but she gets really mad when she hears surgeons make the same jokes. A senior psychiatrist told me that sometimes she jokes about patients, but she feels that residents and young physicians shouldn't because they haven't earned the right to do it yet. But setting those divisions aside for a moment, I think the larger us is clinicians in contrast to people who don't work in medicine. And one reason the risque joking that comprises gallows humor typically travels among peers is the risk inherent in joking across categories. So just as jokes can establish or affirm community or intimacy, as philosopher Ted Cohen suggests, when jokes reveal that we don't see eye to eye, they can harm relationships. Sometimes clinicians cross categories and introduce a joke with a patient, introduce a joking relationship, and a joke about the patient's medical condition with the patient. When that's successful, one reason it might feel good is because the exchange puts them in a peer relationship for a moment. But we have to ask ourselves, who gets to define whether a clinician-initiated joke with a patient is successful? I want to share a personal story to illustrate this point. A few years ago, my sister and I had radically different reactions to a joke that a healthcare provider initiated about my own medical condition. I was showering, and a old-fashioned porcelain shower handle broke off as I turned to turn it off and just gutted my thumb. I had just flown in from a week of rebuilding houses in Katrina. I had to get to a wedding thing, very stressful, so I'm naked, wet, sobbing, and it's like a scene, the redo of the scene from Psycho. There's just blood pumping on the shower. So I'm freaking out. I throw clothes on and go to the emergency room a few blocks down from my house, not my own institution. It's important to know. I get there, and I'm still weepy when I meet the medical student who lets me know that she's never done the halo block that she's going to need to do. This will be her first time to sew up my thumb. And as a medical educator, I realize this is just cosmic justice. I'm still weepy, and my sister arrives because she's picked up my bridesmaid's dress from the tailor that's about to close. It's just a stressful morning. And I'm still weepy as the student is doing this. And I got to say, the first needle stick she did was, you know, like a rocket on reentry, the sparks that were showering behind my eyelids. And I was weeping through the pain, but I was also chatting and joking as she's doing this. And a nurse I'll refer to as Nurse Tough Love was there to demonstrating proper techniques, just starts jamming the needle in my hand to show her how to do this. And the medical student's trying again and again, and I gasp as the needle is probing my cut. And Nurse Tough Love laughed, and she said, "Have you ever had a baby?" And I said, "No." And she said, "May I suggest you don't?" And my sister, sitting there with my bridesmaid dress, says, "Hey, that's not nice. She's being very brave." And Nurse Tough Love says, "I'm just saying, there are a lot of nice ones to adopt." Now, one interpretation is that the nurse making a joke of my pain reaction was offering a shorthand intended to give me perspective, which is, "Come on, lady, this is not so bad. You're fine," right? Or maybe it was intended for the medical student. It was a coded way to say, "Don't freak out. Her tears are out of proportion to the physical pain you're actually causing her." Though the proportion seemed about right. A lot of nerves, team, just FYI. My thumb's still a little tingly. That was a few years ago. My sister interpreted the joke as kicking me when I was down. It was a joking up, joking down analysis to her. That she thought that someone who should be helping me was making fun of me, and she thought I should file a complaint. I thought the nurse was trying to help me, actually, by teasing me to cheer me up or to distract me out of my tears, like a 5-year-old, potentially. She didn't succeed, but I wasn't offended. But I did wonder why it wasn't okay for me to cry. I wasn't thrashing, I wasn't yelling stop, I was talking and joking while tears streamed down my face. And I gotta say, I'm not a crier, so it was oddly liberating to skip my usual show of false bravery and just weep at pain and surrender to care. And I actually resented being pulled away from a coping mechanism that was really working for me in this moment. I want to consider the reverse power differential. So that was a provider initiating a joke with a patient. What happens when patients initiate jokes about their own conditions with their providers? An emergency department physician I'll call Ben, who gave me permission to use this but asked me to change his name, told me this story. A thief escaping from a bank robbery crashed his car, and the police brought him into Ben's emergency room for a trauma evaluation on his way to jail. And that includes a rectal exam, and Ben expected the prisoner to object to the rectal exam, as many of the big tough guys he treats do. Instead, when Ben said, I need to do a rectal exam, the prisoner looked out at the sea of cops and said, "I guess I have to get used to it." Now, I'm not sure if this is a joke about prison rape or cavity searches. Either way, it covers a topic I generally classify as not funny. And if a doctor had made that joke to the patient, it would have been horrific, in my opinion. But Freud suggests that the unafflicted like it when, quote, victims joke about their plight because it relieves us of what he calls the burden of sympathy. Interestingly, in this instance, the prisoner's joke may have had the opposite effect of creating sympathy, because my friend Ben is a very jovial person, but Ben didn't laugh. Instead, the joke humanized the patient for the physician in a different way. I asked Ben what happened in that moment, and he said, "The joke bridged the us-him divide. Here's a guy who has the same dark sense of humor as me. It made me think perhaps in a different time we could be friends." So instead of relieving the physician of his burden of sympathy, this joke seemed to have created a fleeting moment of Cohen's community or intimacy between doctor and patient. I think, as an outsider, as someone who's not an MD, that medicine is an odd profession, in which we ask regular people to act like feces and vomit don't smell, unusual bodies are not at all remarkable, and death is not frightening. We begin medical training by throwing normal 20-somethings into a room of dead bodies and telling them to start cutting. Dissecting a corpse violates strong cultural taboos around death and dead bodies, and historically speaking, the anatomy lab was the site of something called cadaver antics that many older physicians recall very fondly. Making jokes, clowning around with classmates, pulling pranks to scare people with their cadaver parts. Joking like this helps convert corpses into cadavers by framing bodies as objects. And until recently, cadaver antics were a rite of passage, initiation, and enculturation into an ethos that says a doctor is a tough person who can laugh at death. Not just not cry at death, laugh at death. And in the past, cadaver antics were a part of that enculturation, but today they're no longer tolerated. Instead, anatomy students are taught to imagine the lives that these people might have had before they died, to journal about their emotional reactions to being in an anatomy lab, and to discuss those journal entries in small groups facilitated by older physicians in many schools. Many students are asked to think of these deceased people as their first patients and to treat their bodies with the respect patients deserve, except for the part where you're going to cut them up. At the end of the experience, medical students often hold a memorial service for the cremated remains of the people they've dissected. And we do this at our school, and it's very beautiful, where the students write poems and sing songs. And at our school now, they meet some of the families of the people who donated their bodies and discuss it with their families who want to be at this new memorial service and hear what the students have learned. Hear the students thank these people for this tremendous gift they've given them to their education. I want to point out to you that that is a dramatic shift away from the macho, laugh-at-death performance of the role of doctor. And I want you to think of the field of performance studies, the performative elements of what makes you be recognized as doing a certain social role. That shifts the performative elements of doctor toward compassion and connection with the patient's loss as being performative elements that define the role of doctor. By offering an alternate way of coping with the sadness, fear, and tension that surround death, it's possible the modern anatomy lab experience models a different way to perform the role of doctor. Now, I want to share with you my own point of view. I applaud these cadaver lab changes. I'm a strong advocate of backstage changes that make a diverse workforce welcome. And I support efforts to define what I think of as House of God talk, which can be shortened to the acronym HOG talk, as unprofessional. Because shallow bullying and just derogatory slang that gets passed around, to me, coarsen the moral enterprise of medicine and cut providers off from healthier means of coping. However, it's possible that in some areas, the hand-wringing has gone too far. Condemnation of Gallows humor is sometimes premised on a misunderstanding. For example, lumping it together with all making fun of patients. Sometimes it's a double standard. For example, one of the very few articles on this subject contrasts destructive Gallows humor. And apparently to these authors, there's no other kind. Any provider-to-provider Gallows humor they categorize as destructive. They contrast that with what they call therapeutic humor between doctor and patient, which is, quote, grounded on a recognition of the human condition that is shared by patient and provider. But I ask, what about the human condition that is shared between provider and provider? Critics of backstage Gallows humor, who are admirably concerned with empathy for patients, sometimes seem curiously devoid of empathy for physicians. Empathy for clinicians doesn't mean that anything goes. Please don't misinterpret what I'm saying. But I think it means that empathy means that clinicians must be conceptualized as human beings rather than robotic care delivery systems. Two of life's greatest joys are caring for other people and laughing. And suggesting that clinicians can only have one in certain circumstances, I think requires justification. So, let's think about what that might be. What I've shared with you so far is an example of the what and why of medical humanities, sort of trying to start with engaging in something like a 360 review. And we emphasize that at Northwestern because it deepens our understanding of medicine as a discipline, generally. But using that humanities content and humanities methods can also enrich our ethics analysis, thinking about the normative right and wrong of medicine. So I want to get back to David's original ethics question. Was it wrong for them to make that tip joke? I think the underlying ethics question here is, when is a joke a form of abuse? Abuse of a patient, abuse of trust, or abuse of power? So to answer that, there are a couple things I'd want to think about. First, I want to think about who is harmed by any particular joke. You begin by being a smart reader of the joke and doing a power analysis of the text. Is the true target of the joke really a defenseless patient? Or is it a doctor who's defenseless against death, decay, and chronic illness? I'd want to ask about harm to care. Could the joke harm the way care is delivered in the future by biasing listeners' future interactions, either with that particular patient? Or does the repetition of stereotyping jokes about patients like these make the clinician calloused to seeing other people who are in that demographic? I want to think about harm to the profession. Could the joke harm the profession by diverting legitimate anger caused by structural problems, like so many cases that we can never get enough sleep, right? And divert that structural anger, instead of going back to the administration that created this problem, diverting it onto the easy punching bag of patients, rather than using that anger and that energy to make productive change. I want to think about harm to others. I always want to know who's listening to this joke. Gallows humor that might seem ethical backstage can become unethical in front of patients, families, or others because of its potential to harm them. Secondly, I'd want to ask about the clinician's own personal relationship to the joke. I would want to think about intent. Why is this clinician joking? Is gallows humor being used as a helpful defense mechanism when circumstances limit the options for processing something difficult? Like, we want to tell our students, write in your personal reflective journals and discuss it, but we all know in the emergency room that's not an option sometimes, maybe all the time. Is the intent to get through the day by trying to lighten an oppressive situation? Or is the intent to be a jolly bully? I want to think about impact on the clinician. How is this joking affecting him or her? Is it the type of joking that helps clinicians open up to difficult experiences and frees them from intolerable burdens? Or is it the type of joking that cuts clinicians off from experiences or from patients that healthy clinicians ought to be able to engage with? And lastly, I'd ask about frequency. Making truly callous jokes about patients, to me, is like crying at work. It happens, you're human, shake it off. Sometimes it's healthy. But if you're crying at work every day, we would say you're having problems coping with your admittedly very difficult job. So it's the same with gallows humor. A clinician who's constantly using it may need to expand their range of coping mechanisms. I'd also want to see if this joking is part of an ongoing pattern of objectifying vulnerable patients that suggests a deeper bias. So returning to David's joke specifically to conclude. David and his colleagues scattered across the country after their residency. But in the 15 years that passed before he told me the tip joke, they talked about the night the delivery boy died several times on the phone with each other. The whole thing made them sad for years, he said. Wasn't that terrible? They'd ask each other on the phone. How could we eat the food that that poor kid dropped? In the process of trying to do good, did they become bad? I don't think so. To me, the butt of the doctor's tip joke isn't the patient, it's death. The residents fought death with all they had, and death won. Patient care wasn't harmed. The patient in this case had already received the best medical care they could deliver, and he died. The neighborhood's staggering rates of crime and poverty might represent an external obstacle upsetting the residents, but medical residents are usually powerless to alter that kind of structural factor. It's also important to me that the tip joke was told in an empty area with no family, friends, or other patients who could be harmed by overhearing. Now, I'm usually a fan of sunshine tests and total disclosure, so I find the idea that secrecy is an ethical plus in this instance kind of startling to my own general approach to ethics. But when a compassionate professional gets overwhelmed, gallows humor may be a psychic survival instinct. And that's why I think it's not an abuse of patient trust when it's done backstage and for the right reasons. Something that looks maleficent toward one patient may actually be an act of beneficence toward patients who will come next. So yes, if the delivery boy were my son and I heard that joke, I'd want to tear their eyes out. But if I was the person in the next ambulance hurtling toward their emergency room after my heart attack, my assault, my rape, I'd be glad they made that joke. Because they needed to laugh before they could eat, and they needed to eat to be at their best when it was my turn to receive care. I think the motivation of David and the other residents for telling that joke was to integrate this terrible event and get on with the shift. This teenager lost his life bringing these young doctors dinner. How much you think we ought to tip him is a macabre summary of all that's owed in this world and all that can never be repaid. And it looks forward. It's interesting to me that it's a moving on joke, a moving on question. How much should we tip him? In a situation that horrific and that absurd, to me a joke is the rock you throw after the bad guy's already gone, an admission of loss and a promise to fight again another day. When a terrible joke is the only bridge between horror and necessity, gallows humor, I think, can be a show of respect for the work that lies ahead. So tell your jokes. Tell them somewhere I can't hear. Then treat me well when we're together. My friend David is a brilliant, compassionate physician. And because he will serve patients all his life, when he asked me this question, I told him two things about the tip joke. I'm glad he did what he needed to do to treat every patient he'd see that night. I'm also glad that it still bothers him. Because it's good to carry the tension that tells you you're on thin ice. Thank you.
We have time for questions. Would you please repeat any questions or distill them for the web streaming microphone? Questions, please?
Or comments? Am I full of bunk? Hi.
If you believe that the gallows humor is something that one learns and is not just born with, do you think there are any consequences in delaying your start to learning that process? If they used to start learning that process in the gross lab, and now we're delaying that. Is there any consequences?
That's interesting. I hear this about pharma reps, too, about delaying your exposure. I don't see... I think you all are very smart and competent, and you'll need to learn the survival techniques you need to learn. So that's not a concern that's ever come to my mind, but it sounds like maybe it's on yours. Could you tell me your point of view on that?
Well, just what came to mind is that I would rather personally learn that and make some mistakes when a dead patient is involved and not in the clinic, and make a mistake where somebody's emotions truly are hurt, rather than a colleague of mine saying, "Oh, maybe that's where we're out of bounds."
What a great insight. So I'm going to repeat for the tape that the idea was maybe it's better to make a mistake in the cadaver lab, go too far, do that sort of thing, and without a living patient, and be corrected as part of your training, rather than someone who's a patient whose feelings could be hurt. I guess, just to respond spontaneously to that, I think that what I'm interested in is this performance of doctor. And I actually worry at the formative stages that if it's okay to throw around body parts and make a lot of jokes out of this at a formative time, which I would imagine this is scary, threatening, there's all these other things going on, I would rather you learn the performative element of coping with sadness and loss and stress and tension in ways that I think are going to be healthier for you in the long run. And trusting that when you're on the wards or you're doing this and people make a joke, that you will get the training or the correction then. That would be my preference, but I'm open to hearing other perspectives. Thank you for that.
I was just going to say, too, that, gallows humor still happens in the gross lab.
Sure.
And I think that, the push for, when you were talking about journaling and all those things, maybe just giving another option and coping.
Mm-hmm.
That should be something that's also pushed for upper levels as well, to give them more support system, more options to cope instead of kind of relying on the gallows humor.
Absolutely, that the idea that the new approach to anatomy lab is more about expanding coping mechanisms. You can still make a joke in your journal entry that your tutor reads. You know, it's not that somehow you can't still make a joke, but these more active pranks that felt like body desecration, a category gets cut off. So to your point, maybe it's the training is that's never appropriate. You know, but the verbal jokes about this might still be. But I'm sure people go back and forth about that was inappropriate, you know, having this tension about what's okay to say, which is a fascinating one, wonderfully American conversation, right? Yes, sir.
I'd just like to make a comment. It seems to me that these words, you know, how much should we tip him, are a transition. And, you know, I've been to a lot of funerals, and, you know, when family or close friends are involved, there's often a dinner afterwards, and the transition of being funereal to being with people that you like and wanting to celebrate, you know, a person's life. There's this really awkward transition that comes maybe over a glass of wine, or someone says a prayer, and then someone makes a short comment, and then there's a transition. The tone changes, and people begin to talk, and it's often celebratory. And so, from a clinician's point of view, this to me seems like a transition. You know, they used, you know, a joke, you know, but they could have used words that may not have been as effective. You know, boy, that was intense. I guess we better get back to work. But that really doesn't have that sense of transition or uplift or normalization. You know,
right, that there's different and additional content in this phrase that they use. I think your point is really well taken, this idea of the difficulty of transition between difficult and very disparate emotional states. And your example of a funeral is a great one, of the awkward transition between, now we're going to tell funny stories about Grandpa afterwards. We did the solemn part at the funeral, now we're going to exchange the funny jokes about him, some of which are a little bit at his expense, and some of them are just loving, you know, but it's all done in good spirit and good love. That's an example where people have hours to make a transition. Here, what I'm suggesting is clinicians specifically who are dealing with death on a routine basis have to turn it around like this. And so there's something about this rapid cognitive thing, an emotional thing going on, that might be very functional. Now, to me, the two camps, the simplistic way of looking at this is, yes, we have to do that. Life is hard, so we can say anything we want. And I disagree with that. And the other side is, that's just unprofessional. You've got to find other ways. You say, boy, that was intense. You find another way that's never okay. And I think that clinicians deserve a more nuanced analysis that takes both those sides into account, but uses more sophisticated analysis in very context-specific instances each time. Paul, you had a comment?
Just a very profound and exciting lecture.
Thank you.
And you capture something that reminds me of the works of Ingmar Bergman.
Now that's a compliment. We could stop right here, right? Let's wrap this up.
Your comment that, you know, this young man gave his life to bring them a pizza. And Bergman would plumb the depths of that, saying that in this tragedy, there is something about life itself being expressed. And in their eating, they're tying themselves back to the multiple sacrifices that have been made toward that meal. Every time we eat, we're eating a whole lot of contributions that have been made along the way. And that's what Bergman was so concerned about. And while he didn't talk much in his movies, the story came across. Not many missed it. And I think that that you capture that polarity of emotion, but the depth of the experience that's going on. So I find that quite intriguing, and I think that's worth pursuing.
Thank you. Yes, to me, what I thought was interesting was the professionalism dismissal. For those who I think in my argument misinterpret what professionalism is, to just dismiss this and say they're young, they're callous, they shouldn't say that, misses, I think, what Paul is speaking to, of the complexity and the depths of something about human existence that's happening. Another clinician has raised to me that point, casting it in religious terms, that eating that pizza, some people say, oh my God, that's so gross and disrespectful to that they could eat the food that that kid dropped. And others have made the analogy to communion, that there is a ritualistic. He died bringing that pizza. To not take a bite of it would actually be the ultimate act of disrespect, which is a fascinating interpretive lens that one could consider this through. Yes, sir?
I wonder if you suggested there are outside limits, and I wonder if one of the outside limits is, for want of a better word, political correctness. I learned in 30 years of teaching family law, there are things that women can say about women that I can't say.
That's right, and you know why?
There are things that blacks can say about blacks, and gays can say about gays.
True.
I can't say. There are 3 letters in this morning's paper about an editorial cartoon about Cain that is racist. You know, it was, if this had appeared in the Defender, maybe it would have been all right, but in this one, it's not allowed.
Yeah. So I'm going to disagree with your term political correctness, and I'd call it civility and respect.
Civility, yeah.
Yeah, so those terms aren't synonymous. So what I would say, sometimes people use the word political correctness as synonym for things I'm not allowed to say and I'd like to, and it's not right. But it sounds like we're on the same page, civility and respect and human dignity. So it is true, so that I offered the terms of joking up and joking down, and in-group and out-group joking, and I think that explains some of the reason that I could make a joke about women as a category in a way that someone who's not in my shared category can't. And the thing, I've heard some older physicians complain that being at work isn't as fun as it used to be. There used to be a lot more joking. And one thing that's interesting, and this is just a hypothesis, is the joking they miss. The in-group used to be us straight white men, and so the joking that was allowed, was it really about being physicians exclusively, or the differences between us and our patients there were a lot of other differences that would define in-group, out-group. Now in-group is just those of us with medical degrees, but we're gay and we're straight, and we are of all different races and all different religions and all different genders and all different ages and all different ethnic backgrounds. And so really the only us them joking left is us versus patients, and that's our medical conditions, and we all get those medical conditions too. So if on that basis of joking, I can see why it has gotten less fun. Yes, ma'am.
I just want to thank you for your thoughts on this topic. I find it really interesting.
Oh, great.
I wanted to add, as an educator, I had a recent experience that really highlighted to me the importance of not prematurely judging a joke, and so I appreciate how you explored the different reasons for jokes. And I encountered a situation where an intern who was on call in the ICU had a patient that I was consultant on as a palliative care physician, and we anticipated that the patient might die. And I wasn't sure if this intern had ever had the opportunity to pronounce a patient dead or had to break the news to the family. And so I asked him, I said, so have you ever pronounced a patient dead before? And he said, well, only in the ED where you just slap the glove and it hits the wall and goes in the garbage can. And he expected me to sort of laugh and say, oh, haha, yeah, isn't that funny? Because he was coming from that culture where, that's
turn it around.
Yeah. And, being a palliative care doctor, my first reaction was just that I was horrified. I mean, how insensitive, how callous. And then I thought, well, he probably he's telling me that he has no clue, and that he's nervous about this probably. And so I asked him, I said, would you like me to share with you the way that I would do this, and maybe that could help you if this happens tonight. And he was like, absolutely, anything you can tell me to help me. I've
Terrific.
done this before, and please.
Yeah.
And I think that if I had just judged him and said, with that, sort of attitude that, oh, that's unprofessional, and how dare he speak of, a patient's death that way, it's inhumane, or there's no compassion, that I would have missed an opportunity to teach him something. And it might have kind of created a cultural divide between two cultures, the culture of the ED, where I'll see him again in the future, and the culture of ICU and palliative care. So I think that in terms of relationships and teaching and medical education, I think it's very important that we don't, just label this as unprofessional right out of the gate.
That's a great story and a great illustration of the kind of things I'm interested in this area. Also, I want to
Summarize, please.
I walked over thinking it would pick it up. The idea that Dr. Earnshaw, offered was a student who'd been in the ED and said when she asked if he'd ever pronounced someone dead in this palliative care context, and said no, only in the ED where you flip off the glove and it hits the wall and that's that. And she was at first taken aback and then realized, okay, here's an opportunity, and said, would you like me to share with you how we pronounce here? And the student was very eager and said, oh yes, please. So what I want to suggest also is this idea of performance studies, the performative elements of being a doctor. Young students are figuring out how to, it's not just the jacket, though that's a really big part of it, right? What are the outside things that mark me as being a clinician? And some of it, how do I carry myself? How do I talk? How do I show that I'm one of the in people? How do I perform? And it's so funny to me. So the student being like, that's how when the glove hits it, is also maybe testing, like, yeah, did I sound like a doctor? Did I do it? Is that, yeah, no, yeah, no, oh, no, 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 oh, okay, no, no, oh, I should do it like this. Like, so we're all mimicking and modeling, particularly at those early stages. And when I teach ethics in a first-year course, and if I'm doing the small groups, I just love those moments when you're talking about something and a student says, like, informed consent. Patients have no idea, da-da-da, and I'm like, have you ever seen a patient? No? Cool. You know, you're 21. Like, but they saw, you know, 80-year-old clinicians speak like that. They adopted the carriage, the tone, the phrase, and they repeated it back. And I think they're waiting. It's like a toddler who falls and is like, looks at you to learn if they're hurt. You know? And so we're all doing that at different stages of our lives as we're learning a new thing. We try it on and then we kind of look around to the people who really know. We're like, yeah? No? Did I pat? No? Oh, okay. You know. So I think you have a really great insight to take that and realize that's what that student's doing and model for him. Actually, no, you're not done yet. Right? Good. Thank you. David?
I think that's an important point, and I want to dovetail onto that.
You stand right here.
In technology, we often talk about fear, uncertainty, and doubt when we don't know what's going to happen in the future. And I would add on a couple of things to consider. If someone is having a off-the-reservation humor event where they tell a joke at somebody's expense or it seems to be particularly cutting or cruel, that we need to better ascertain from the learner's perspective, from the student or the resident's perspective, what is the fear, what is the uncertainty, what is the doubt. I'd also add on what is the anger, what is the frustration that's driving what's coming out of your mouth right now. And to try not to be judgmental, saying the thing that I really don't like for people to say, which is, that's inappropriate, because that doesn't tell me what is inappropriate. Instead, to say, what are you feeling right now? What is disconcerting you or what is upsetting you right now for you to say that? And to try to elicit from the learner what it is that is causing this joke to come out the way it is, particularly if it's something that is particularly insulting or particularly cruel. Because every once in a while someone will go ahead, and I've heard God knows how much over the last 30 years in a variety of circumstances from, you know, from DC to LA, people saying a lot of things that were extraordinarily cruel. And that did not need to be said in the way they did. And a lot of times it was because they were extremely frustrated. They were pushed their personal physical limits. They were fearful. For instance, when I was out in LA, and people were routinely being admitted and dying of HIV, and these were 24-hour admissions because they would come in and die. And people were absolutely scared to death. And there were horrible jokes that were being told about this whole circumstance. And you realize what it was. Everyone was absolutely petrified. And at that point, they didn't even know if it was bloodborne versus airborne vector. They were that petrified. So I think that you need to try to get from people what it is that you're angsty about inside, that you're coming out with what they think is a lighthearted comment, but it really does not have a lot of helium but a lot of lead, and that there is a need to process that more effectively than what was perhaps an ineffective and maybe unkind joke.
Absolutely. I think I'd go back to the term rapid truthing, and sometimes someone is rapid truthing content, and sometimes they're rapid truthing emotion of, I am terrified, I am so resentful of this, I hate this situation, and that's what they're rapid truthing. And when you're unclear to say, what is it you're trying to say? Can be a helpful question. When someone tells a joke and they just say, wow, that surprises me. What is it? What do you mean by that? And they might say, I've been up for 3 nights and I can't take this anymore. That's what I mean by that. Or it might be, I mean, like with Bill's example about the second base, what I mean is you guys spend 2 hours on these tests and you're not willing to go to the hard part, which is we need to let this baby go. Great, say it that way if we're not okay with making a second base joke. But let's figure out what are we really talking about. Other questions or comments? I know some people have 1 o'clock events. Please feel free.
All right. Thank you very much. We thank you so much.